It is a gorgeous day at ACC 15 in San Diego, California. You know, there's a common belief, although not well documented, that repeat cardiac monitoring is frequent in patients with suspected arrhythmia. So in early 2015, the Journal of Health Economics and Outcomes Research featured a cost analysis and clinical outcomes of ambulatory care monitoring in Medicare patients, describing the Diagnostic Odyssey. So we're going to talk a little bit about the Odyssey. And I'm with Dr. Sunil Kumar Agarwal, who is an MD, PhD, and a fellow in cardiology at the Mount Sinai School of Medicine, and Judy Lenane, who is an Executive VP and Chief Clinical Officer for iRhythm. We'll get to what iRhythm is in a moment. First, let's talk about this Diagnostic Odyssey. It really is for most patients, isn't it?
It is. Essentially, people always had these yieldy devices which they have to wear, and they recorded the rhythm for a short duration, and we were not always sure of the quality. And over time, it has panned out that the quality is very good, and people are much more comfortable wearing them over a long time and doing their activities of daily living while wearing them. So I think we have made a lot of progress in terms of the device design of what they can do for us.
So what did you learn from the paper that came out in the economics analysis?
What we looked at is we actually looked at the Medicare SAF file, which is a statistical analytical file, and we actually wanted to answer the question, once a patient has an index Holter, what happens over a 2-year period? And we all thought, those of us who've been around patient care and diagnostics, was that it was linear, that there would have been one test, a Holter, then moving on to an event monitor, mobile telemetry. And what we actually saw is that patients get repeated Holters over and over. And we know that a Holter on its own is only about a 15% diagnostic yield. So you're not getting an answer, but you're using the same technology over and over again.
Right.
And that was really what we were able to demonstrate in the Medicare analysis. And we showed, again, a large burden of cost is being spent by Medicare on these testing that really are not giving answers.
So for a moment, first let's talk about iRhythm. Mm-hmm. What's the option? What now are we looking at?
So really what iRhythm is we're a digital healthcare company, and what we've created is a way to take a large data set from a wearable biosensor. We're one of the leaders in wearable biosensing, and basically what that means is we figured out how to get a device to stick on a patient that they can go about and live their life, which is unfortunately for medical devices has not been really great. So we took the burden off the patient. We made it very easy for the patient to wear. We're recording and storing every single heartbeat for up to 14 days. We then take this large data set, this big data file, send it up to the cloud, do rapid analysis with our proprietary algorithms, bring it back down to earth, and then clinicians actually create reports for physicians about what's important in that data set, because 14 days of data and 1.5 million heartbeats,
right.
what's important? And we've been able to do that and do it very quickly, and then we provide that information to the physicians, and we also look at what do they need to pay attention to. How do they, because physicians are just basically being bombarded with data. So now we're helping them, give them information of this is what you need to pay attention to. This is what happened to your patient while they were living their life, and we were capturing all their arrhythmias.
So how does this change the Diagnostic Odyssey?
So I think the longer recording, for example, I will come back to the study we did. And in this study, we had 70 to 90-year-old free-dwelling people in the community who are not sick in the hospital, and it will be wrong to really put an invasive monitoring or a device for them. But we don't know. We keep hearing that there is a lot of paroxysmal AFib, meaning people with arrhythmias and they don't have any symptoms, or they last for so short a duration that the routine ECG monitoring in a clinic visit for 10 seconds may not capture them. So what we found in this group of 237 participants from the community is there is a burden about 6% of atrial fibrillation. Atrial fibrillation, we know, is associated with 4 to 5-fold increased risk of stroke, which can be reduced by 60 to 70% with appropriate medications, including anticoagulation. But the other interesting part is about 50% of these people we identify with atrial fibrillation had persistent atrial fibrillation, meaning we'll identify them anyhow with a 10-second ECG. But the other important big group, which is 50% of the people, they have paroxysmal atrial fibrillation, meaning we will not capture them on a 10-second ECG. About 5 of the 7 patients who had paroxysmal atrial fibrillation detected, they weren't aware that they have atrial fibrillation, and they were not on anticoagulation. And this is a special group of population because we have been following them for about 20 years now. We had multiple EKGs on them. We had all the hospital records of these people. And even then, we find that 40% of them, they weren't aware that they have atrial fibrillation, and they are not on medication, which might potentially reduce the risk of stroke.
Here at ACC, you have a poster, Arrhythmia Burden Among Community-Dwelling Elderly Using 2 Weeks of Ambulatory ECG Recordings. So what did you find?
So essentially, we showed the things I talked about, that about 50% of the patients in the community have paroxysms of atrial fibrillation, which will not be captured with routine EKG. But we also find that a lot of these participants who are 70 to 90 years old, they have other subclinical arrhythmias. For example, 4% of them have greater than 3 seconds of pauses, meaning their heart is not beating for 3 seconds. Also, we looked at some of the ventricular arrhythmias where the heartbeat comes from the lower chambers of the heart, which is not considered good, which we call NSVT, non-sustained ventricular tachycardia. It was present in 27% of the participants. So we see a huge burden of these subclinical arrhythmias. The relevance of them really needs to be studied, and we will be doing that further. But we find tons more subclinical arrhythmias.
But you can't understand their relevance without understanding they exist and knowing that they're there.
Yes, that is the first thing, but we also have brain MRI data, and we had presented some data earlier at the AHA which showed that some of these arrhythmias are associated with, in fact, more subclinical subcortical stroke, which is small strokes.
So prognostically, they could be important.
They could be very important, especially with the epidemic of dementia on the horizon in this elderly population.
Now, let's talk a little bit about the device itself. Okay. We could look at it now, and what do you want people to know about this?
So what's important about the device and this new generation of technology is, one, the adhesives are very comfortable to wear. So that can be worn for up to 14 days. Because as Sunil talked about, arrhythmias are elusive. So now to be able to have something that you can have for this 14-day period, and we're recording every single heartbeat. And the other thing that's about the device that's really important is patients can easily live with this. They can go on and live their life. They can shower. They can exercise. They can live their life and be able to have all the data collected. And then the data is easily moved and uploaded to the cloud to be able to then take that information and create the data set that the physician needs to really get to an answer. Does this patient have an arrhythmia, or to rule out that arrhythmia? Very important. Symptom rhythm correlation, again, is very easy because you want to capture data as patients are living their life.
And the big problem with a lot of this data is there's too much of it. And so this corrals the data for you, is what you're saying, and that makes a big difference.
That does, for a practicing physician.
So you can take 2 weeks of data and get a pretty quick analysis of just what went on during those 2 weeks.
Absolutely. You can get the averages, heart rate, and also I think there is more and more potential for research in terms of when people get arrhythmias, etc., etc.
Right. One of the things that was very important in Sunil's study is that this concept of subclinical atrial fibrillation or silent atrial fib. True. So it's something that, again, in this population of 75 to 90-year-olds, that we actually really were able to see there's a lot more atrial fib going on that's not being documented. So this notion of we need to be looking for it, we need to be watching for it, we need to find it so we can be proactive as opposed to reactive to that stroke that they have.
Right. So. Well, this is just one of the technology stories that's coming out of ACC 15, so please check out CardioSource World News because we have a variety of different stories to choose from. And for CSWN, I'm Executive Editor Rick McGuire.